Okay, let's transition to targeted therapy. The first targeted therapy ever to be approved in a gynecologic cancer, either cervical or ovarian, was bevacizumab, a monoclonal antibody against vascular endothelial growth factor. And that continues to evolve with the FDA approval on June 13th, 2018 of frontline. And I'm interested, Elena, you've followed the NCCN guidelines closely. I don't really know how important the NCCN guidelines to me, but I do know that they're important to payers. So tell me about the NCCN guidelines now for the frontline use of bevacizumab, which, by the way, have been updated on March 8th, 2019.
So the NCCN update really summarizes the debate about bevacizumab in the primary setting. And this is a debate that we've had now for quite a bit of time. And the debate is such: it does improve progression-free survival, but there is no overall survival benefit. And the debate becomes, how important is that to the patient, that interval of time? There's studies that show that progression-free survival is beneficial because the patient is able then to get to the next platinum setting and get response with that. But a lot of people believe that overall survival is the key, and without benefit in that, bevacizumab should not be level 1.
Excellent summary. I'm a little, certainly not offended by your comments, but I don't agree with overall survival as an endpoint in frontline ovarian cancer. So Katie, tell us why the NCCN would even mention such, what I would say is a preposterous idea.
I mean, I honestly can't explain it. We increasingly know, and this is true not only in the United States, but in Europe, we have data that's very convincing, we need to publish it, that even though we struggle to show overall survival advantages with our frontline interventions, even though in both the US and Europe, the incidence and the mortality of ovarian cancers remain the same, the prevalence has markedly increased because women are living longer. So
SEER just showed that.
we just showed that. And in fact, in Europe, we had to argue that it was still an orphan disease because it's crossed the threshold by prevalence, so it's no longer an orphan disease, but it is by incidence, so we can still say that. So these incremental, or sometimes not incremental, sometimes meaningful improvements in progression-free survival in one particular study that may not look like overall survival in that study, but they do matter over time to how long our patients are living. So, and bevacizumab is a part of that story. I mean, that story started developing 5 to 10 years ago, which is when we got bevacizumab, and now we have bevacizumab in every arm, or every kind of setting, and we've shown, at least in 2 separate studies, that if you keep using it, even if you progressed on it the last time, it still works again. So these improvements in PFS translate into improvements eventually in overall survival.
And they're meaningful.
And they're meaningful to patients, and they're meaningful to how long they live. And so I don't understand that decision,
So
and I don't
Brian,
agree with it.
Who in your practice is the best candidate for frontline bevacizumab?
Yeah, no, the bevacizumab is in all arms of therapy for ovarian cancer in my practice. And right now, truthfully, all of my patients with newly diagnosed ovarian cancer, if they're not a BRCA patient, which I know we're going to get into, I'm looking forward to it.
But I love
But if
it.
they're not,
That's right.
they're going to get maintenance
100%
therapy
agree.
with bevacizumab.
Yep.
Now, the specifics of when we start the bevacizumab, I know the studies are based on starting it right up front with cycle 1 or 2 of chemotherapy. Sometimes it takes a longer conversation with patients to tell them that they're not just getting treated over 6 cycles, it's going to be a longer treatment. But giving Bev after their chemotherapy, I think, is helping them live longer, and it has a longer PFS. And remember, ovarian cancer now, women are getting 8, 9, 10 lines of therapy. To translate what we give in the first line to get that to an OS, who cares?
So technically, the June 2018 label is post-operative. So in the neoadjuvant setting, you kind of have to be careful with reimbursement. According to the label, technically you'd start it on cycle 5, not on cycle 4 while she's healing. I think what comes into it, that the all-comer benefit is modest. 6.2 months, hazard ratio of 0.62. But there are some patients, the stage 4s, that actually might have a survival advantage. But I think cost plays into it. Tell me what your sense is of the cost and what you think biosimilars will do if and when they become approved.
Right. So, Brad, you really pointed out the key in here, and the kind of the elephant in the room is that there's a lot of society cost to these drugs, which doesn't usually stop us from its use. But yes, I mean, again, in my population, I select the patients who are the worst prognosis, and that's what the study showed as well.
Society stage 4.
Stage 4.
And that's reasonable.
Right. And I think the new addendum now is that it's not women in my practice with just BRCA deleterious mutations. It's also women with homologous recombination deficiency.
Well, but frontline PARP maintenance would be off-label unless you have a BRCA mutation, but I understand that you want to do that, and we'll come back to that. So again, bevacizumab was approved initially in platinum-resistant disease, and then platinum-sensitive with OCEANS, carboplatin gemcitabine, and then also with GOG-213, carboplatin paclitaxel, and then ultimately, as we talked about in June 13th, 2018, frontline. Brian, we're still struggling, though, with what the right chemotherapy backbone is in recurrent disease. I think in the Aurelia study, we've agreed it's weekly paclitaxel, but in platinum-sensitive, it's more complicated. So at ESMO, Pfister reported a platinum doublet with Bev, 2 different platinum doublets. Tell us about that study.
Yeah, so what you're referring to, Brett, is using platinum as a backbone, using platinum with liposomal doxorubicin and bevacizumab versus platinum with gemcitabine and bevacizumab. And basically, you know, in summary, they found there was a slight improvement, I would say, with the liposomal doxorubicin arm, or that was the experimental arm. But the side effect profile was improved in that arm as well.
No surprise, right? PLD is easier than gemcitabine.
Limitations, they didn't look at Taxol.
There you go. They did not look at the
That's
213
They didn't
regimen.
look at 213. So who's to say, you know, how can you make a definitive conclusion without that? You can't. In my practice, in those patients that are 6 to 12 months or 6 to 18 months, if they've seen taxanes within a year, I'll probably go to one of the other doublets that don't contain a platinum. But if they've had, you know, 2 years, a year and a half, 2 years out without disease, I'll go back to carboplatin and paclitaxel.
Yeah, so we used to have 2 opportunities in platinum-sensitive relapse, carbogem, carbopaclitaxel. Now we have a third, maybe even a preferable carbo-PLD. I'm struck that the carbo-PLD, which is, again, pegylated liposomal doxorubicin, that's an ideal opportunity for the patient with unstable diabetes because you got to give a lot of steroid with paclitaxel. So if you say, look, her diabetes is a challenge, her hyperglycemia, you have the opportunity to start with carbo-PLD frontline.